Hello, this is a presentation on opioids and the recommendations for prescribing.
Opioids are drugs containing opium or its derivatives. Opioid drugs produce their effect by acting on the opioid receptors, which are found in the brain, spinal cord and sites outside the central nervous system. All drugs that have morphine-like actions, naturally occurring or synthetic, are called opioids.
The National Reporting and Learning System, NRLS, patient safety incidents to be reported through the NRLS. The risk of death as serious harm with controlled drugs was significantly greater than with medication incidents generally. Incidents involving overdose of controlled drugs accounted for 89 of the 128 incidents reporting of serious harm. 5 controlled drugs, morphine, diamorphine, fentanyl, midazolam and oxycodone, were responsible for 113 incidents leading to serious harm. Potent opioid analgesics are frequently involved in serious medication incidents, often because of incorrect dose calculations. This information is accessible on the Opioids Aware website on the Faculty of Pain Medicine.
To make it easy, we have written some easy do's and don'ts of prescribing opioids for inpatients. Do take a drug history and continue pre-hospital analgesia, including opioids. The ward pharmacist can help with this. Do consider age, renal and liver functions when prescribing opioids and adjust the dose accordingly. Do consider opioid-sparing adjuncts such as non-steroidal anti-inflammatory drugs if not contraindicated. Do review opioid prescriptions regularly and aim to reduce or stop as healing progresses. Do refer patients on opioid substitution therapy such as methadone to CGL, that's Care, Grow, Live, and seek advice from the pain team if the patient is in severe acute pain. Do consider previous side effects patients may have had to opioids and consider an alternative. Do co-prescribe laxatives with opioids if not contraindicated. Do prescribe antiemetics on the as required section of the drug codex with opioids, and do always prescribe naloxone with all parenteral opioids.
The don'ts of prescribing opiates. Don't co-prescribe regular weak and strong opiates. Examples of this are prescribing codeine regularly alongside modified release morphine such as Zomorph. Don't co-prescribe modified release oral opiates and transdermal opiate patches such as Zomorph and fentanyl patches. This is because you will have 2 long-acting opiates. Don't prescribe more than one route of administration, such as prescribing morphine as IV and oral. Don't prescribe more than one PRN opiate, such as prescribing Oromorph and codeine. Don't prescribe IV morphine bolus doses as PRN analgesia. These should be stat doses to break the cycle of pain. For ongoing pain management in acute pain, consider a morphine PCA.
Some more considerations when prescribing opioids. Consider if patients can absorb oral analgesia. Oral analgesia is the route of choice if this is available. If not, consider IV, sublingual or transdermal routes if this is more appropriate. Consider renal function when prescribing opioids, as renal impairment can cause accumulation of metabolites. Use caution in prescribing. Consider dose reduction, alternative opioids, or discussion with the pain team in patients with renal impairment. Consider patient's sedation score or AVPU before prescribing or administering opioids. Consider previous opioid history. Opioid-tolerant patients will require higher doses in acute pain and will need multimodal analgesia. Seek advice from the pain team.
Opioids and acute pain. This is a quote from Opioids Aware website and also from the guidance by the Royal College of Anaesthetists on surgery and opioids best practice that they produced in 2021. They said that immediate release opioids are preferred in the management of post-operative pain when simple analgesics such as paracetamol and NSAIDs are not effective enough to allow the achievement of agreed functional goals. The functional goals that they're referring to are the patients are able to deep breathe and cough and mobilise. The reason that we are now looking more to use immediate release opioids is to decrease the risk of respiratory impairment and to avoid long-term continuation of opioids such as happened in the past.
Respiratory depression is a serious side effect of opioid analgesia. The treatment is IV naloxone. The dose is 100 micrograms IV and repeat PRN, that's as required, after 5 minutes, for a sedation score of 2 and a respiratory rate of less than 8. If the sedation score is 3, regardless of the respiration rate, this requires naloxone as above. Sedation is an earlier sign of opiate overdose than reduction in respiratory rate. Seek anesthetic assistance if required. This is the sticker we use for prescribing naloxone. It can be found on any of the surgical wards where parenteral opioids are used and can be ordered from pharmacy.
Did you know the risk of harm increases substantially at doses above an oral morphine equivalent of 120 milligrams a day, and there is no increased benefit to pain management? Tapering or stopping high doses of opioids needs careful planning and collaboration. Again, this is from the Opioids Aware website on Faculty of Pain Medicine. And these are the references that we have used for this presentation, and this presentation will be uploaded onto the Acute Pain TrustNav page in the forthcoming weeks.